Hi, I'm Mohammed Jahanzeb. I'm a medical oncologist in Boca Raton, Florida. I focus on lung cancer and breast cancer, and I work with Florida Precision Oncology, a division of 21st Century Oncology.
Hi, I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C.
I'm Michael Lanuti. I'm a thoracic surgeon at Mass General Hospital. I'm the director of thoracic oncology in our division of thoracic surgery, and I'm an associate professor at Harvard Medical School.
Hi, I'm Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I am chief of thoracic radiation oncology and stereotactic body radiotherapy and director of clinical trials.
Hi, I'm Michelle Ginsberg. I'm a radiologist and I'm director of cardiothoracic imaging and vice chair for education at Memorial Sloan Kettering Cancer Center in New York City.
We now go to Dr. Lanuti for a high-risk patient, stage 2. Dr. Lanuti, you want to talk about this case?
Yes, sure. So this is a 77-year-old female that I've known for about almost a decade. Currently, history of emphysema with an FEV1 that's quite low, but carried a history of resected stage 1A left lower lobe lung cancer, where I did a segmentectomy back in 2013. And at that time had some limited lung function. And during surveillance, had a right upper lobe lesion that started to become more solid and was empirically treated with 48 gray of radiation without a confirmatory biopsy, and then subsequently followed longer, and now has again another suspicious FDG-avid right upper lobe lesion that has raised suspicion that's 9 millimeters. And then I just had summarized what I did back in 2013 for a 2.2 centimeter resected adenocarcinoma that was node negative. At that time, that tumor, where we were doing NGS testing, which we no longer do routinely on early stage tumors based on poor reimbursement, was a KRAS mutant. So hypertension, spinal stenosis, COPD, as I mentioned, and some GI type issues with bowel obstruction back in 2011. Her history was a 50-pack year smoker who quit right around the first diagnosis of lung cancer and no family history. I would say relatively asymptomatic, although albeit dyspnea with exertion, can walk a few blocks, can go up a flight of stairs, but beyond that gets quite dyspneic. Her performance status is still a 1. She was quite small, this lady, 42 kilos, and she had manifestations of emphysema on her chest x-ray. These were the PFT results, nearly a liter FEV1, and a DLCO that was under 40%.
Tell us about pulmonary function tests and why you do it and what's acceptable to you.
So pulmonary function testing puts an objective number to someone's clinical performance status. And I'd say that it's been one of these standardization tools across the country and perhaps the world that's done with similar technique, where the numbers can be translated across. In normal testing, we test for forced expiratory volume in 1 second, which often gives us an idea of pulmonary capacity. People who don't smoke, you're in that 3-liter range, and it really is based on the size of the patient. We look at total lung volumes. The larger the lung volumes, the more obstructive the disease can be, and the more air trapping, and the lower the lung volumes, perhaps the more restrictive the pathology can be, similar to like pulmonary fibrosis. And then there's this technique of diffusion capacity, which is done in different ways. Some with just a helium mixture, some with a body plasmathography where you sit in a box. But this is essentially looking at how good is the lung as a filter and how good is it at transferring across a membrane oxygen. And things that are under 40%, we tend to worry. DLCO can be affected by other things than lung, can be affected by your hemoglobin, and in fact, your cardiac function. So that's the short version of pulmonary function tests.
Great. So what you're saying is that nature has built maybe up to 60% of surplus function in lungs, but once you are down to 40%, you have really no reserve. You can't afford to lose much.
Yeah, and so at that, when you're hitting the 40% mark, usually we have to do other things to assess someone's surgical safety and candidacy. And those other things include putting people on stairwells and just doing a stairwell climb test. And then there's things that are cardiopulmonary exercise testing that have many different levels, where we can start to understand someone's exchange of oxygen.
Excellent. So let's have
So-
Dr. Ginsburg talk about these images, or would you
Yeah,
like to say a few more things before we do that?
This is just the recap of way back when we first took out her first lung cancer. Dr. Ginsburg can comment.
This is the 2.2 centimeter nodule, which is spiculated, and it's in the superior segment of the left lower lobe, and on the corresponding PET, it is FDG avid.
Great.
And then, so that was treated with segmentectomy with negative lymph nodes, as I mentioned. In 2015, we saw this lesion starting to develop in the upper lobe. Dr. Ginsburg can comment here.
This is a 1.2 centimeter spiculated nodule in the right upper lobe, and on the corresponding PET CT, this is avid as well.
Yeah. This we treated with an empiric SBRT.
The right post SBRT changes seen at the right upper lobe site, and on the PET CT, we see that we actually don't have the corresponding, but there was not much of an uptake of this lesion, which corresponds to SBRT treatment changes, which are actually very tough to separate from recurrent tumor. And generally, we follow them with sequential studies like CT scans and, if needed, a PET CT. But in addition to that, there's a new 0.9 centimeter right upper lobe spiculated nodule, which is FDG avid. You see the PET CT on the bottom right, which shows that hot spot, which is a little brighter. And then at the same time above it, we have a more inferior image from that same PET CT, which shows a right hilar lymph node, which is FDG avid. And other lymph nodes were not FDG avid.
So as I alluded to her, she was limited by lung function, so she's not a surgical candidate for additional pulmonary resection. But I think here it is obligatory for us to understand what that FDG avid hilar lymph node represents. It's in a funny position. It's not in the upper lobe distribution of drainage. It's more in the lower lobe or middle lobe distribution of drainage. So 12R is a lymph node that we call hilar that sits between the middle lobe bronchus and the lower lobe bronchus. We were able to sample this with EBUS, and she had a previous mediastinoscopy, so I just used EBUS to stage all of mediastinum at the time. We staged level 7, and honestly, there weren't much targets for 4R, 2R, and 4L, so that's why you don't see any additional histology there.
Level 7 being subcarinal, you mean?
And level 7 subcarinal, thank you. And so this was a squamous cell, P40 positive, TTF1 negative. And the question would be, and so then she was subsequently staged with brain MR, which was negative. So the question to the panel would be, how would you treat something like this? And I've already taken surgery off the table.
If surgery is off the table, then we have Dr. Robinson with his radiation, and we can ask Dr. Levy when he would discuss systemic therapy with the patient. Dr. Levy, why don't you go first and talk about systemic therapy potentially, and then we can talk to Dr. Robinson.
Yeah, this is a fascinating case of a patient, unfortunate patient, who's had seems like a separate lung cancer compared to his first lung cancer, at least based on, I believe, the pathology of the first one that was wedged was the adenocarcinoma. This is a squamous cell. And this is where I would partner with the radiation oncologist in patients who are not surgically resectable, who have N1 disease. We generally do try to offer concurrent chemoradiation. We know that concurrent chemoradiation provides better outcomes for patients versus sequential, although again, this is the eyeball test, looking at the patient to see whether they could tolerate concurrent or not. And the PFTs are a little concerning, and would certainly turn to Dr. Robinson about what type of radiation could be fit in. I don't know if you want me to talk about what types of chemotherapy I would offer.
I think if you want to comment on histology and what we are limited by and what should not be given, that'll be useful.
Yeah, that's what I was going to talk about just briefly. Patients with squamous cell carcinoma, we generally do not offer pemetrexed, which is a well-tolerated drug and efficacious in the adenocarcinoma patient population. For squamous cell, we generally offer a platinum with taxane. Now, the board answer is platinum etoposide, SWOG 50-50 regimen with radiation if you're going to do that. But I would say in routine clinical practice, weekly carbotaxol would be given definitively with radiation if the radiation could be safely given in this patient.
If I might interject, just to give the kind of the way we were thinking about this. So there's a small right upper lobe, 9 millimeter nodule that's FDG avid that we didn't biopsy. Then there's no parenchymal lesion in the lower lobe or the middle lobe. There is a SBRT resolving area in the upper lobe. And so the question is, where is that 12R lymph node coming from? And that's the puzzle, if you will, in the absence of a parenchymal lesion in the middle or lower lobe.
Great. So Dr. Robinson?
Yeah, I think we need to address that first, because really everything Dr. Levy and I are going to discuss is an assumption that this represents a true stage 2 lung cancer. I think the potential, particularly for squamous cell carcinoma, which, as we know, is constrained within the airway, there is a potential that there could be an occult lesion in the right lower lung in the main airway. I would assume that is something that would have been looked at during the course of the bronchoscopy for the EBUS. But this also, I think, belies the point of sometimes treating what you know versus what you suspect. And this would probably be a scenario where, even though anatomically it's suspect, we may have to just go with the best available evidence that we have and proceed forward.
Is there a role for doing additional lavage or various lobes to see if you get malignant cells?
So that's a technique that was used years ago for lavaging various parts of the lung. The yields have been historically low. When you're looking for a mucosal lesion with a visible eye, it's often missed. So sometimes we use different modalities like narrowband imaging, which allows you to look at more specific aspects of the mucosa. There's this old fluorescence bronchoscopy that some pulmonologists use. It really highlights intramucosal lesions or in situ lesions. In this case, I must say that I didn't see anything grossly or on narrow band, but I think it's a good point.
Great. So going back to the uncertainties, Dr. Robinson, the case is what it is.
Yeah.
As I often say to trainees, when the data are not there, the patient still is. What would you do?
In this case, we may just need to commit to treating this patient for what we know is a suspected stage 2 in the setting of a prior surgery and prior SBRT. For me, the main issues, and I think Dr. Levy nicely elaborated on this, is going to be understanding what the patient can tolerate. Certainly, I agree that concurrent chemoradiotherapy would be the best available option for a patient like this if they could tolerate it. The two complicating factors for me as a radiation oncologist are going to be the prior SBRT and their overall lung function. The prior SBRT is something that is an issue because the body never quite forgets the injury that has been delivered to that pulmonary parenchymal tissue. And so we would use techniques to minimize delivery of additional radiation back into that area, and those lesions are quite close to each other. Having said that, there is a considerable amount of data about this exact scenario of multiply treated areas in the lung after SBRT, and it turns out that while there is a slightly increased risk of developing radiation pneumonitis, it's quite modest and relatively safe. This is where each center would have its own toy that it would use, whether it be protons or some form of special IMRT or various forms of delivery of radiation to minimize that risk. The second one you mentioned is the pulmonary function. Interestingly, from a radiation standpoint, while I think that's a significant consideration for anatomic resections, at least for more obstructive disease, COPD that's obstructive, there's really no clear correlation between PFT values and risk of radiation. In fact, actually, there's somewhat paradoxical associations such that the worse your score is, so if you took an objective measure like a gold score, there's actually a lower risk of pneumonitis. As I often say, you need pneumo to get pneumonitis. That's different, by the way, if it's a more restrictive disease or if the patient had something like interstitial lung disease where radiation actually has a much higher risk of pneumonitis. So in this case, I would say that if the patient's capable and Dr. Levy thought that they were a candidate for chemotherapy, I would recommend concurrent chemoradiotherapy with, as he mentioned, carbotaxol per RTOGO 617.
Great. So a provocative question for Dr. Levy. Tell us about PrecisCa trial. You mentioned it. Tell us about the design and why this patient would not have gone on that study, and whether you would still extrapolate from that study and apply to this patient.
I knew that question was coming. The PrecisCa study, as we've talked about it briefly. This was a study looking at unresectable stage 3A and 3B, both adeno and squamous cell, who'd received definitive chemoradiation. Some of these patients, 25 to 30%, got induction chemo followed by concurrent chemoradiation. If those patients had all achieved stable disease, at least stable disease, they were randomized 2-to-1 to a PD-L1 drug, durvalumab versus placebo. Again, placebo at the time of the trial's inception was the standard of care. The patients received these regimens in 2 parallel arms every 2 weeks for up to a year. Bottom line was there was an improvement in progression-free survival initially reported out in the New England Journal of Medicine 2 years ago, and more recently, an overall survival advantage independent of histology, independent of PD-L1, although there was a pre-specified analysis that PD-L1 zeros didn't seem to benefit. There were some questions about this. So it benefited all patients. So for stage 3 unresectable, yes, that's an easy one. What do you do in this case? Well, I can tell you again, the board answer is you don't give it. My answer is I would consider it. I mean, this is a patient who's had, 3 separate lung cancers in 8 years. And so I would consider offering durvalumab, given the benefit we've seen from PrecisCa, given the understanding that this drug does work well also in squamous cell. I would have a discussion with the patient. I would have a discussion with the patient's insurance company, most likely. And I would probably consider offering it for this patient. But that's, again, not the board answer, but that's what I would do in clinical practice.
Great. So with that, I would put up the last slide for the case for Dr. Lamuti to comment on. We have covered a lot of this stuff in our discussion.
I guess I should probably comment on that last one since we didn't bring it up, and that's what they did.
Yes.
So what I didn't bring up was certainly in the absence of a patient being a candidate for chemotherapy, and perhaps even in certain patients where it's possible, it is also of a fashion recently, based off of data from our group and others, that you can give a more accelerated course of radiation, so stereotactic-like radiation, where you give higher doses per day over, say, 10 to 15 radiation treatments. And this is called hypofractionated radiation. So, for example, at our institution, in patients who are not chemotherapy candidates with stage 2 cancer, we would give that same 60 gray over 15 treatments instead of 30 treatments, essentially doubling the dose per day, and then using technology as a way to minimize dose to the esophagus and heart and so on. I would say that the suggested plan here is quite novel, but certainly not standard, but I think within the accepted norm of things you could consider. particularly if chemotherapy was off the table.
Any concluding remarks, Dr. Lanuti?
I think that chemo plus radiation was definitely on the top of the list, as you mentioned, both of you. And I think that the medical oncologist felt that she was slightly fragile and that those two would tip her over. So we went with the no chemo option, albeit probably less efficacious.
So this is again a good illustration of how treatment has to be individualized, and one size doesn't fit all. And patients who are being seen by a group of doctors always end up having the best decision made for them, and hence the whole concept of multidisciplinary care. So this is a very nice case to illustrate that. This has been a truly enlightening discussion. I thank all of you. These were phenomenal cases, all requiring multidisciplinary input, and it's such a treat to have world-renowned experts discussing them and coming to a consensus. Thank you all.